Hey guys, Don here. Welcome to Podiatry Practice Mastery, and I'm going to go over the $1,000,000 minute. This is the things that I did to get the practice to the $1,000,000 mark and beyond. I want to start with a funny story. It was about 11 a.m. In the practice. This was on a Tuesday this is the day. And all of a sudden we heard this loud fire alarm in our office, and all of us, we had to get all the staff, all the patients out of the room. Everyone had to go outside, and we're like in the end of January here in Massachusetts, so it's freezing outside. The wind is blowing, and it seems like there's a fire station like 2 minutes of, like, you can throw a rock at it from where we're at, and and it took like 15 minutes for the firemen to come, and they looked at it, and what it was is, on the third floor of our building there was a guy, I think one of the construction guys, was vaping. So he was vaping in there, and it did our fire alarm. And the funny thing, there's an oral surgeon, so these kids are coming out with stuff in their mouth, and they're bleeding and things like that. I think they didn't get caught mid-procedure, but everything ended up working out, so that was kind of a funny thing that happened. I had an 86-year-old female I was seeing, and she ended up doing okay. I asked one of the people, "Why didn't you go to your car?" She said, "Well, I wanted to shiver a little bit so I'd lose some calories." So that's that. I also got a question. Someone emailed me. They said, "Don, tell me a little bit more about a scribe." If you want to learn more about scribes, I would go to my YouTube. And the cool thing about YouTube, if you go to it, you can put in the search bar Scribe or Virtual Scribe, and it'll give you all the videos that I have on it. But basically, the Scribe has made my life 10 times better as a doctor. He is virtual. He's in my pocket. He's from India. His name is Murali, and he's been with me for a couple of years now. It took me about 6 months to train him. The first one didn't work. Second one didn't work. Finally, my third one did work, and it's working very well. Kind of a 2.0 version recently. I've been using Murali. I have a WhatsApp, and so sometimes he was complaining he wasn't getting a full hour lunch, because I really never take a full hour lunch and things like that. So what I've done is I've done kind of a hybrid. Sometimes when he wants to take lunch, what I'll do is I will see the patient, and then I'll dictate or into WhatsApp without patient identifiers, and then he takes that and he'll put that into the note. So sometimes he actually likes this better. So for example, if internet goes down in India where he's at, I'll just transcribe and he'll do it after. I guess that's the way that transcription used to be. He knows how to do all my notes. The only drawback when you do that is I don't have my orders done. So my orders and the follow-up appointments and other types of things like that are not done. So I have to put those in manually, which sometimes I forget and the staff get mad at me. Whereas he does a good job remembering. And also he doesn't remind me of stuff. So for example, a lot of times he'll remind me of doing they're due for a circulation study and an ABI, or they're due for a diabetic foot exam. Okay. Today this was 18 patients. I had a couple of openings, but then they filled in some of those openings. So 18 appointments, an hour and 20 open, and it looks like they added on 3 patients. So there was really, I think, maybe only one opening that ended up being maybe 1 or 2. Okay. The first patient was a 51-year-old. This patient, I gave a prescription for ketoconazole. They came back in for a biopsy follow-up on the skin. I was wondering if it was eczema or dermatitis. Did not come back that way. They had some correct toes they were using due to neuroma. The neuroma was better with the correct toes and anatomic shoes. And then I did the ketoconazole. So because of that, I did a level 4 because it was a prescription. Next patient was a 77-year-old gentleman. This was a nice guy. His job is working with at UMass here. There's a mindfulness type of course, and so he is, I think he's Colombian, and he goes around the world and teaches these mindfulness courses. So he gave me a nice present. He gave me a book on this mindfulness in Portuguese, because he knows I speak Portuguese. So that was kind of a funny thing. But he had a matrixectomy bilaterally. Another patient was a 29-year-old guy that came in. He's actually a MD PhD student, and he needed a matrixectomy. He was treated somewhere else with a phenol, and it took on one side, didn't take on the other side. Another patient came in. This was a 51-year-old. She was here for EPAT number 2. Actually, I'm sorry, not EPAT number 2. She had she was here for a new patient with a second opinion, and she had seen another doctor locally. Now, I've come to find that really heel pain, or just in general, second opinions are really my best patients, because they've tried many things already. They're already on phase 2. So I went through my whole explanation, and she ended up getting EPAT. I'm going to do amnio on the second visit, and I'm going to scan her for orthotics on the first visit. So this would be like my MVP, my most valuable patient that was set up. She was a little concerned about how to pay for it. We have care credit, so I offered her that. But if I could focus on doing second opinions for heel pain, that would be great, because everyone else around here, they only do physical therapy and cortisone injections. They don't do anything else. And so I think because of that, it would set us apart if that's the thing I wanted to focus on. So what did I do? I asked my virtual assistant to do a couple of blog posts on second opinions for plantar fasciitis and Achilles tendonitis, hopefully to get some more lead flow in there. And then you could have some kind of a specific, let's say, a page on that, second opinions or things like that, because I think a lot of people are looking for second opinions from other people around, and maybe even having a tab on the website for like second opinions. Another patient was a 52-year-old. This was EPAT number 2 for plantar fasciitis. Another girl, she's a physician's assistant. We're finishing up a 30-year-old female. Now, she had pain, not to the Achilles, but the retrocalcaneal bursa area bilaterally. And this really kind of flares up on her when she does a lot of standing during her rotations. So she had these long surgical rotations. We kind of went over 2 options. She's had some shockwave on her peroneals that have helped, but I think since the pain is so deep posteriorly, what we did is we did a little bit of a cortisone injection into that area bilaterally, kind of far enough away from the Achilles, but to kind of get deep in there to try to calm things down. I'm going to call her today and kind of see how she's doing with that. Another patient was a 86-year-old female. She came in she had a lot of swelling, and she had an ingrown toenail. So I recommend compression socks, and I just trimmed out her ingrown toenail for her, and I got x-rays because she had some foot deformities, and I'll see her back as needed. So these ones are as needed. Next one is as needed as well. This patient, he had hammer toes. I took out a little bit of an ingrown toenail. He'll come back as needed as well. He was concerned if he needed new orthotics, but his orthotics actually looked fine, so I did not have to do new orthotics for him. Another patient was a 71-year-old that came back for a nail sample follow-up, and there was no fungus in that nail sample, so no need for a follow-up. I'm wondering, like, even with all these nail samples, sometimes I'm thinking about not having them come back because that's not really a high-level visit. And so if there's maybe a way I could do like a nail sample, then call them or have them follow up if it is positive, that might be a better way of doing that. Another patient, she came in, a 65-year-old female. She had some heel cracking, so heel fissures. So I have this protocol, you probably heard me say it before. I recommend they get a 42% urea. They do that in the morning, and then at night they put on these sleep and heal, these gel socks, and that tends to work well. If you guys have anything better than that, let me know. She also had 2 porokeratomas that we did lesion destruction on, and she had 2 calluses. So those calluses I trimmed off, and I got x-rays for her. And then the last patient in the morning was a 52-year-old female. She injured her foot in a soccer game. Her heel was injured, and she's a very active 52-year-old, so for her I recommended 3 sessions of shockwave. She was previously being seen by one of my colleagues. I did an ultrasound on her, and she will have him do that shockwave. So I kind of teed him up for the shockwave. Afternoon, there was a 69-year-old female came back. She's feeling much better after her plantar fasciitis. She had 3 sessions, and this is a 6-week follow-up. Since she was feeling so good, I did a video on that. So I'm trying to do videos of patients that are getting better with the treatments I want to see more of. So I'm doing videos of like a status post shockwave and orthotics and things like that. Another patient was a 77-year-old patient. They got diabetes, got a diabetic foot exam, did the nails, shoe prescription, and they did not want to be seen every 3 months. So I'm going to see them in 1 year. Another patient was a 52-year-old. This was a patient that had a bunion, wanted to consider bunion surgery. So we went over that. They would be a good candidate for an Austin bunionectomy. So we're going to schedule that with Christy. So the way we do it here is I have Morali, while I'm in the treatment room, he sends a case which is through our EMR, and sends it to Christy, my staff, that schedules surgery. So I have this surgery scheduling Google Doc, and it's basically everything that are needed for my surgeries. And he just copies it, pastes it, puts in the information, and so Christy knows. So I think that's an easy way of doing it, kind of how you do things, put it in a Google Doc, and then my scribe just copies it, pastes it, so I don't have to do anything. But she also had some plantar fasciitis. And so we started the initial treatments with that, including like the night splint, morning stretch, meloxicam, things like that. And if it's not getting better, she'll let me know. I told her we should probably fix that first. Another patient was plantar fasciitis number 1 visit, and also had an ingrown toenail. So we did the whole same thing I always do. Morning stretch, foam rolling, meloxicam, and then come back in 3 weeks for an ultrasound. And then there was also another female. This was kind of an added-on one. This one came in for a painful wart, and that was removed. They wanted to do the wart the same day, and so I removed 2 warts on her foot. She had been dealing with this for a long time. I went over the other options, but she wanted kind of the quickest thing, so I scooped those out. Another patient came in. This is a second opinion, 92-year-old female. Was seen by a podiatrist twice for another one for an ingrown toenail, and her toe just looked all purple. So did her 5th toenail, and so I was concerned about circulation at 92. They gave her a couple rounds of antibiotics. Nail didn't get better. I didn't feel comfortable avulsing the nail until I got a vascular workup. So I texted a vascular surgeon friend of mine, and he's going to see this patient just before I do anything. I didn't think the toe looked infected. They were concerned, but I think it's more of a circulation thing. Another woman was a 67-year-old female. She's pretty active. She has a cavus foot type, and so she fractured, I think it was maybe 6 or 8 months ago through her 5th met. Kind of in a typical Jones fracture, and it healed up, but then just due to her foot type, she fractured through again, unfortunately, so I had to go back into her walking boot, did another fracture code, but the problem is I offered her to kind of put a screw down there just to stabilize it, because it's the second time. I tend to do that I've done it in the past more in athletes, more so than like 67-year-old females, so I did not offer to do that, or I said that would be if it maybe does it one more time. Then finally, there was a patient. He came in. He has this kind of unique pain, just proximal to the first med head, and I think it's like a FHL, tenosynovitis, or he thinks it's a sesamoiditis. He's done 3 sessions of shockwave, felt a little bit better. Usually, when I only had a radial machine, I did 3 sessions with radial, and then if they needed another 3, I would do radial and focused. Because he was in my other office, I don't have the focus machine. I have an unfocused machine, that's softwave, but I did do that. So he's going to set up another 3 sessions, number 4, 5, and 6, for that area. And I tended to focus more just proximal to the first med head, kind of in that arch region, and trying to calm that down for him. He's just been having this pain just for a long, long time. He said that he stepped years ago on some peg, and I think it may have caused a little maybe deep tissue adhesions in there. It doesn't really seem like nerve pain, but it seems like it's more of a deep pain. Anyway, that was the day. That was the fire alarm. So once again, if you guys have any other questions or things you want me to address in these little short rants, let me know. And go to email me, Donna at podiatrypracticemastery.com. If you just like this, let me know. I've heard a lot of people saying they like this format, and it's kind of helped their practice. But if you do other things differently than I do, let me know, okay? Because I'd like to get better, one, and I want to help you guys get better as well. Okay, thanks.